Each year, thousands of mothers and newborns in low-resource settings die from preventable causes. Often it is because young doctors are forced to learn in real time, moving directly from the classroom to the clinic with few chances to practice before facing life or death emergencies. By simulating emergencies in a safe learning space, doctors can practice and refine their response before lives are on the line. At Stanford's Center for Advanced Pediatric and Perinatal Education, hands-on simulation empowers clinicians to practice life-saving interventions safely. Now, through the Stanford African Scholars in Global Health Program, physician educators from Africa are working with Stanford mentors to bring this expertise home.
Being a pediatrician is the best job in the world. Which other specialty do you find your patients actually changing before your eyes? Which other specialty do your patients, when they're well, literally bounce off the bed? And so this is really what keeps me going, the fact that the work that I do impacts not just today, but generations to come.
Being a simulation instructor is really amazing because I think it's one of the ways you can train people without putting patients at risk. And it's really amazing looking at my students, health providers practicing without the fear of making mistakes. So I hope to do a low dose, high frequency model, basically doing a very brief but regular training to really allow the frontline healthcare providers to practice their skills, refine their skills, and also improve the way they communicate, the way they handle high-stake emergencies.
Simulation is really about recreating reality. And who better to recreate reality with than newborns, where split-second decisions have to be made. If you get them wrong, they have very dire consequences. I'm hoping that we will make a difference in terms of our newborn mortality rates, that we would have increased capacity of faculty and staff, that we will have frontline staff who are well trained, and that overall there'll be a better culture of safety and quality improvement in the department.
Simulation is invaluable as an opportunity to practice in a setting where real patients can't be harmed, where the mistakes that you make really don't actually directly affect a patient, but also you can create a situation in which you replicate what could happen to a real patient, and have teams understand the ramifications of their behaviors, whether it's positive or negative. But debriefing is where the real learning takes place. And so actually simulation with debriefing is what is the package that makes this valuable.
Now, this is critical for us in sub-Saharan Africa because our skills are pretty much the only thing that we have. A lot of times we cannot do tests. Either they're unavailable or even if they're available, they're expensive. People can't afford to do that. And so having good skills in terms of knowledge, in terms of performance, but in terms of communication and situational awareness and things like that, these are the things that help you make a difference in patient care. As times have evolved in Africa, as more medical schools have been established, as the class sizes have increased, we can't afford not to have simulation. Otherwise, we're going to end up with doctors who are half-baked, who do not actually have the right knowledge and skills and attitudes to carry out clinical care. And we have to start looking at it as a way of teaching. This is an educational methodology that is so important in medicine because the stakes are so high.
I think people, they tend to say that simulation is expensive because they focus on the shiny part of simulation. Everyone will be focusing now, you hear virtual reality here and there. You hear about high fidelity mannequins, but it's not about the technology. You can even do simulation with very basic equipment. I talked how we use some animal tissues in Rwanda to do some skills training. We've been using some wooden box covered with some tissue to just simulate a laparotomy and students, they practice with that. So really having that exposure, but also being ready to do mistakes and learn from those, I think we changed the idea of simulation is expensive and we can't do it in sub-Saharan Africa.
I think in terms of equity, both sides need to see the value that they bring to the table. That has to be front and center, that there's value on both sides. There's a lot that we have to learn from here. But as people working in low resource settings, we've also had to be very innovative and resilient, and to learn to do more with less.
Having that opportunity to just share my experience from Africa, and people that are really willing to listen to me, and even wow, whatever you are doing is amazing because you are doing a lot with little. That's also one of the things that can make the opportunity being equitable.
As somebody who works in the neonatal resuscitation space, I hear a lot about conducting neonatal resuscitation and clinical research to try to improve neonatal resuscitation in low and middle income countries. But I actually don't personally have my own sort of direct experience or knowledge of what it's like. And so actually learning from you about what is the construct of your hospitals and how do clinicians come to be in these situations and what preparation they do or don't have has really helped me actually have a broader understanding for some of the work that I even do outside of simulation.
She's an amazing person and I learn a lot from her. I learn a lot from how I call her Mama when we are
crying.
So it's sisterhood, is the opportunity to network, learn from their challenges that they've been facing before, but also just sharing the same passion of improving the care we provide.
Beyond the program itself, even just the community and just being with other scholars from other parts of Africa, living with 3 other African women over the last few weeks. That's really been amazing. And I think that we have formed collaborations that will endure for many years to come.